Hey, and did you know I'm currently accepting new patients in New York, offering both in person and telehealth visits? And I also provide telehealth for patients in Michigan, with North Carolina coming soon. And I also offer coaching, both intimacy coaching and menopause coaching, nationally and internationally. So look us up on www.femvhealth.com. I am an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about the current understanding of female orgasmic disorder. But before we get into it, a few things I want to make clear that this is not any type of medical advice. If you have any questions about your sexual health, make sure you go see a healthcare provider. And if you have any questions about your religion, make sure you go see your friendly neighborhood religious leader. This is a Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. And today I'm super excited to have on with me again the fabulous Dr. Rachel Pope. And Dr. Rachel Pope, for those people that may have missed the first episode and have not met you before, if you could just introduce yourself.
Yeah, so I'm Dr. Rachel Pope. I'm a gynecologist who specializes in female sexual health and menopause. And I'm so excited to be here today. So thank you for having me on.
Yes, I'm so glad that you were able to come on and we were able to coordinate this so quickly. So I am excited to delve into the paper that you recently published, which is so exciting. And it was called The Female Orgasmic Dysfunction, Current Understanding and Guidelines. Is that correct?
Yeah.
And so it's published, you said it was published recently online for ACOG, which is so exciting. And soon it'll be out in print. But I'd love to just kind of see what inspired you to write this review. And what do you think is the biggest misconception physicians still have about female orgasm?
Yeah. I mean, so I have to give credit to my co-authors too, Anna Myers, Jean Marino, and Amin Samud. They all did a ton of work to bring this to the finish line. So it was a team effort, but I'm happy to be the spokesperson for the team. We all take care of women who are going through difficulties with intimacy, whether it's desire, whether it's pain, or orgasm. And I think orgasm is one that really makes women not feel great about their sexual life and about their sexual health. And yet they rarely bring it up unless they're asked about it because there's still so much cultural taboo around pleasure for women. And I feel like we as a scientific community know so little about the female orgasm that really I was hoping to put this together as sort of a call for attention that here's what we know, but there's so much more that we don't know. And I want the scientific community to kind of chip in with me and work on figuring this out.
Yeah, absolutely. So what do you why do you think the female orgasm has been so understudied compared to male sexual function? I mean, I could probably answer that for you, but I'll let you answer.
Yeah. Yeah. And I would love to hear your thoughts on it too. But I honestly think that so many people just don't pay attention to it because they don't think it matters. And they may not even be consciously saying that it doesn't matter, but because we look at cancer for women, we look for endometriosis and pain conditions, disorders of the ovaries and the uterus, we don't really think that much about the clitoris because we think, oh, there's really not that many things that could go wrong to it. And even in my paper, I quote Aristotle, who, however many years ago said that the female orgasm doesn't seem to influence conception. So a woman can still get pregnant even if she doesn't orgasm. Then it's kind of like if a woman's not orgasming, nobody really thinks that there's anything really that needs to be done about it. So I really just feel like people don't think or realize that it matters.
Yeah. And I think that's so true, right? Because it seems that, and I think that you've mentioned this before, is that a woman's worth really depends on her ability to reproduce, right? And that's kind of what Aristotle is saying, that it, as long as she's able to still have a baby, it doesn't really matter if she enjoys what she's doing or if she's experiencing pleasure. It's just, she's basically serving a function, right?
Exactly. And that's what I think is so actually cool about orgasm is that women can orgasm really only for pleasure. Like the clitoris, really, its main purpose could be just for pleasure. It doesn't have to have anything to do with reproduction. It doesn't have to have anything to do with urination, like, the penis does for the man. And so I think it's actually really cool that women could have this organ that's solely for pleasure.
Yeah, I agree with you 100%. I mean, I think that to me is so fascinating, right? That is the sole function and it's just to give women pleasure. So your paper describes the female orgasmic disorder as underrecognized. Why do you think so many women and clinicians don't talk about it? And you mentioned a little bit about the stigma, the
Yeah.
taboo, the discomfort.
Yeah, I think there is a lot of stigma, but I also think that for women, orgasm is very subjective. It's not so much for men. There's a very objective thing that's happening for men when they orgasm. But for women, there's not necessarily. And every woman might describe an orgasm differently. And I also have to mention, it's been brought to my attention since publishing this paper that women don't always want to be considered that this is a disorder or dysfunction if they haven't orgasmed. They might still have pleasurable experiences and intimacy without orgasm, which I think is very valid and worth mentioning. But again, it's so everyone's experience is so different. And so that makes it a lot more difficult to kind of understand if there's a problem or if there's an issue or if there's something that you could actually do to help a woman achieve orgasm.
Yeah, I think to your point, Emily Nagoski always says that, pleasure is the measure, right? So if you're experiencing pleasure, that you don't have to orgasm. And we know that, Dr. Barry Komisarek says the same
Yeah.
thing. He's done so much research on orgasm, but he says that,
That's right.
it doesn't have to be your main goal. You can enjoy the
Right.
journey and not actually orgasm. And so many things, right? Like sex therapists will say the same thing, but
Yeah.
for some women, it is really important and they find it difficult to enjoy sex. And for a lot of women that get into midlife and beyond, they'll say that, well, I never really enjoyed sex to begin with. And now it's just become a chore. And I've never had an orgasm, so I don't really see what the point is. And I've had,
Yeah.
a few women say to me that if I never have sex again, it's not a big deal because I never enjoyed it to begin with.
Yeah, I know. And that's valid if you're really not interested in spending time on it. I totally understand it and that's okay. To each their own. But also if it's something that you want to experience as a human, I mean, we should as physicians be able to help people do that. And I think there really is science behind this. And that's what I'm excited about. And that's why we publish this because there is some science and we're trying to put the pieces together so that we can all help women because really they deserve to be able to orgasm and experience that just as a part of humanity, really.
Absolutely, and I think that, just as we spoke about, for some women, it's not that important, but for a lot of women, it is important, and so
Yeah.
that's where I think your paper really comes in handy, and it's fantastic. So, can you explain what actually happens in the brain and the body during orgasm?
Yeah. So I kind of think of it as a series, when thinking back to physics, when we had to set up these like series of electrical circuits where you'd have like one thing, and if everything is going right, then it leads to the next, to the next. I do think of orgasm as something like that because along the way, there can be different sort of barriers that would then derail someone from being able to get to the climax or the orgasm. And the first thing that tends to happen for women is arousal. Arousal could happen from looking at something, from reading something, from touching or being touched. There's lots of different things that are going on in our brain to start with arousal. And at the same time, we know that dopamine and serotonin are behind that. And you can also experience the first barrier of arousal and the barrier to eventual orgasm at that step. The next one is generally excitement. And this is when the brain gets the rest of the nervous system involved. And that goes towards the clitoris, that goes towards the pelvic floor. All of the nerves are being recruited to help with the pleasurable sensation. And again, a barrier could be if someone's experiencing lack of sensation or if someone's experiencing pain that would sort of derail them from continuing on. The next step tends to be engorgement of the genitals, and that's blood flow that's being shunted towards the genitals and again, the clitoris. You're going to hear me mention the clitoris a lot. But that blood flow we know is really important because that brings in moisture and so then the lubrication. So that arousal kind of continues on towards more excitement and lubrication and blood engorgement. And here we see more sort of barriers that could happen. So if someone has a vascular issue like diabetes, or genitourinary syndrome of menopause, if the hormones are off balancing that vascular supply, then we're going to see some issues with orgasm there. The next one is the sensory input to the clitoris or the clitoral complex. And we can talk more about that. It's not just the glands of the clitoris or what we see. It's also the entire complex, which goes along down through the labia, minora, and majora. And here we might see the barrier through clitoral phimosis, where there's like a thin layer of skin actually covering the glands, or through nerve pain like pudendal neuralgia. And then after that sensory input, the rest of the spinal cord is integrated. You know, women talk about feeling orgasms down into the soles of their feet, right? We know that, like you said, from Barry Komisarek, his research and Dr. Irwin Goldstein together, they have really showed the entire spinal cord integration during arousal leading towards climax. And then at climax, there's actually this loss of vigilance. So loss of really caring about what else is going on. And if you are a person who experiences anxiety, if you've experienced trauma and this sensation is going to trigger that, or if you're distracted because you have a million other things that you'd rather be doing right now, that is going to throw the train off the tracks at that point too. And when you get to, if you are able to continue on towards climax, the pelvic floor muscles contract, and that actually helps to release the oxytocin and the prolactin, that flood of neuroendocrine hormones that then creates this overwhelming pleasurable experience for women and this sense of sort of calm that comes afterwards, and also can lead towards partner bonding. But again, even at that level, we know that things that interfere with oxytocin and prolactin, that may also derail this whole process.
Yeah. I love that. I love how you break it down so succinctly, and I think that that's really important. And because you break it down that way, we can kind of evaluate where, like you mentioned, the train is being derailed, right? We can kind of break and see, well, okay, so is it during arousal, or is it during excitement? Is it during engorgement? Is it during, orgasm? Is it during? Because I've had patients that have vaginismus, right? And tightness of the pelvic floor. And they're not able to experience orgasm, which makes complete sense because if they're not able to relax those pelvic floor muscles and those pelvic floor muscles start to contract when they're having an orgasm, then they're not really going to be able to have that full release during an orgasm. And so it's really good to know.
Yeah, exactly. Or I'm sure you've had patients describe sort of like feeling this arousal, like they're going up a roller coaster and then it just kind of plateaus. They don't get the release. And
Yeah.
oftentimes I see those are my perimenopausal or menopausal patients where the vascular or the hormone aspect to the genitals may be what's happening there. Or they might be on an SSRI, and for some reason that dopamine and the serotonin is being affected. So I think the more that we understand even what inhibits orgasm, the more we can understand the therapeutic opportunities we have behind helping people orgasm.
Yeah, yeah, and I think, at this past Ishwish, um, Dr. Goldstein, right? He was starting to do that, would break up the orgasm into all those different,
Yes,
right, sequences so that he could target it with specific medications and exactly what you were
exactly.
talking about. So, there's a huge, obviously, emphasis on the clitoris, and we know that, that is kind of paramount. But why do you think, that anatomy has been overlooked for so long? I mean, I can't even tell you if I remember it being taught in med school. I don't know. Were you taught about the clitoris?
Yeah, but very briefly, right? I mean, I remember in anatomy lectures learning about it. I learned more in residency, to be honest. Once I was in OBGYN residency, I learned more, but also again in the framework of pathology. looking for vulvar intraepithelial neoplasias, looking for, things like that. Not so much in its functionality for orgasm, or if we even wanted to pathologize it, what happens when someone isn't orgasming, right? And so I think that comes from this not wanting to embarrass a patient or not wanting to talk about something that is, again, about intimate pleasure. Because if the sole purpose is intimate pleasure and there isn't a whole science behind it, or if it doesn't really matter, then why would we go through the effort of learning about it or asking our patients about it? And so I feel like it all comes down to culture. When we can blame medicine, but really medicine is shaped by culture.
Yeah, 100%. And especially in cultures, right, where there is a lot of sex negativity or a lot of shame and taboo around it, you're definitely not going to learn very much. Definitely, and female pleasure, forget about it, right? Like
Yeah.
that's just
Yeah.
so
Yeah.
taboo for a lot of people that
Total.
that would definitely not be something that was focused on. So you mentioned that about 80% of women require clitoral stimulation to reach orgasm. How should that change the way we educate our patients and our couples?
Yeah. I mean, I think it's so important to even just say that to women, because what we see depicted in movies, on TV, in movies, like women are just kind of spontaneously orgasming with vaginal penetration. We don't see this whole series of events that I've just outlined that really needs to be coordinated in order for a female orgasm to happen. And so I think that is helpful for a woman to know. And then, even a step further, it's helpful for women to know what the anatomy of the clitoris is, because it's not just the glands, although that's a big part of it. It's also the cura and where things are being engorged through the labia, too. And also, I feel like when women are experiencing pleasurable sensations vaginally, it probably is because this clitoral complex is actually indirectly being stimulated. I don't think there's that much specific to the vagina, although we know that science is evolving there too, and there's erectile tissue inside the vagina. But I do think that a lot of it comes from the indirect stimulation of the clitoris.
100%. I had Dr. Emmanuel Giannini on
Mm,
last year, and he did,
yeah,
you probably remember him from Ishwish, and he's in Rome, and he talked all
yeah.
about the clitoral urethral complex. And he
Hmm.
talks about how all of that, right, that complex, that the tissue, the nerves that come
Yeah.
from, they
So
all
interesting.
intersect. And as you were mentioning, that it's not just the glands that we see, which of
Mhm.
course we know is like the tip of the iceberg for the clitoris, but it's actually right the crura that come down into the labia, and what we consider is the G spot is probably actually where all of those come together, right at the top, the
Amazing.
anterior surface of the
That's amazing.
vagina.
And in
Yeah.
fact, I have patients who tell me that if too much direct stimulation is put on the glands of the clitoris, then they can't get an orgasm, because there are so many nerve endings on the clitoral glands that they can
Yeah.
actually be overwhelmed, right? Or
Yeah.
overstimulated.
Yeah.
So yeah, it's fascinating.
Yeah, and we just learned a couple of years ago, right, due to the research of Dr.
Yeah. Claire Peters.
Oloko and yes, Dr.
Yeah.
Peters, that the clitoris has more than 10,000 nerve endings, right? So,
Yeah. It's
yeah,
incredible.
and that was only recently.
Yeah.
So
Yeah, exactly.
that tells you.
Right? Because people thought it didn't matter.
Yes, yes, and before they used to say that it was like 8,000, but then we learned it was greater than 10,000. So what surprised you the most, you think, when you were researching the neurobiology of the orgasm?
So I love thinking about how health and medicine fits into evolution. I think it's really interesting. I studied anthropology when I was a college student, and so I like thinking of like what's the evolutionary, advantage. And like we mentioned, maybe there isn't an evolutionary advantage for the human female like orgasm as Aristotle thought. But what zoologists who, obviously I'm not a zoologist, so hopefully I'm not getting this wrong when I read these papers, what they have found with animals, specifically rabbits and ferrets, is that the same neuroendocrine release that we see for women's orgasm are released with ovulation when
Mm,
they reflexively ovulate. And so this thought was that, okay, orgasm might have been linked with a reflex ovulation, whereas, these animals were having sex, and to procreate, there was this ovulation and orgasm together. And of course, as we know now, you don't need reproduction for female humans to ovulate. But I think it's really interesting that that might have been where things, started.
Yeah.
And, we've obviously, come a very long way where we don't need that. But I just thought that's really interesting. And maybe that would explain some of the linkage for procreation and evolution. But I don't know if that's super nerdy. It's just something I think is really
Yeah,
interesting.
no, it's fascinating, right? And we also know that there's like a slight surge after there's ovulation of testosterone, right? That we
Yeah.
get. So which makes sense. That's the body wants us to procreate and have sex and have a baby, right? That's kind of what the body is doing, getting itself ready. So it's very cool. So let's talk a little bit about the orgasm gap. But why do you think it exists?
Yeah. So there's this great graph from one of the papers that I referenced that shows, how by basically 18 years old, 100% of men have reached orgasm. They've figured this out. But really, like 80 to 90% of women will orgasm by their 30s or 40s, and still we never get to 100%. So that's the orgasm gap, that at least 10% of women will never have an orgasm. And I think that it's because it's undervalued. I think if you think back to that series of what's needed, you do need this sense of psychological safety. You do need this sense of being able to lose vigilance where you don't care about anything else. And if you're thinking about, how do I look? Does this person like me? If you're thinking about the other person, that also kind of derails this train from getting to climax. Again, if you're on a medication that inhibits orgasm and you've always been on that medication, there's so many opportunities, unfortunately, to kind of make things challenging for women. And again, I would point back to culture. Really, it's not, when we think at movies and we look at our pop culture, it's not about the woman's pleasure. That's starting to change. There are some really good examples where that is starting to change. But in general, I think that there's like this sense of embarrassment about women's bodies and about their pleasure, and it may take more time and it's not going to be as obvious when it happens. Again, we hear about women faking orgasms, right? You can't fake a male orgasm quite the same way. So I think for all of those reasons, the orgasm gap exists.
Yeah, I agree with you. I think there's so much there, and like you mentioned, there's so many areas where this orgasm could definitely get derailed. I feel a lot of it has to do with our sex education as well, right? Like I feel that, we are not really teaching our, children about pleasure. And I think that that is one of the biggest problems that we have in anatomy. I think that we just don't focus on it. And so many, I'm sure you get this too, is so many women will come in and they do not know their anatomy. They don't realize they have like three separate holes, and one of them, a baby comes out of, and they're confused about the whole thing. And it's not until, right, you show them a mirror and you're going through the whole anatomy with them and they're like, wow, or there's so much discomfort and they're like, wow, do I really need to take a look at this? Do I really need to hold this mirror?
Yeah.
Should I, I
I
don't feel
offer a
comfortable.
mirror all the time to my patients, and I have to tell you, a lot of them decline. They
Yeah.
don't want to look, and that's
Yes.
kind of sad to me.
Yeah.
But
Yeah.
I think you're 100% right. Education from the very beginning, removing the stigma of shame around it, knowing what things are based on science, right? Like, I just think we should focus on the science of it. That takes away the personal aspects of it. That takes away the judgment around it. Science is facts, right?
Yeah.
And so I think it could be reframed that way, and that would help a lot of women. I also think it's interesting that if you don't know what feels good for yourself because of your own exploration, how could you teach a partner or tell a partner what to do? This one paper that was referenced in our study also showed that same gender couples orgasm more frequently than heterosexual couples. And again, it's probably like, you have your own anatomy, you know what feels good. So that communication piece might be a little bit easier. And then maybe there's more communication. I'm not sure, right? But I do think that if we're not familiar with our own anatomy, how could we expect a partner to be more familiar about what makes us feel good?
I say that to my patients all the time. I say,
Yeah.
it's just right. Like we expect so much of our partners or whoever we're involved with. We expect them to like read our mind, but they really can't read
Yes.
our mind. And especially
Yeah.
if there's like if there's, I just think that if there's a lot of shame and taboo associated with this or just discomfort around your own anatomy, you're not going to know, you're not going to be able to tell people. And guaranteed that if you are, especially from the same culture or whatever religion, that your partner probably also has those same hiccups and stigma and taboo.
Right. You're
And
so right. Yes.
so they're not really going to know, or maybe they thought it
Yeah.
was wrong to learn. And so, there's so much
Yes.
there that I feel like we really
Yeah.
need to address that. And, it's a lot of times I feel like it's giving yourself permission to experience pleasure.
Yeah. You're so
And,
right. It is. It
and
is about
it's
giving
about
yourself permission.
yeah, and knowing that it's not wrong and that if it was wrong, you wouldn't have an organ completely,
Yeah.
just for that sole purpose, which is
Exactly.
pleasure in women, right? So
Yeah. Yeah.
it's just so much there, I think. But so your article discusses how expectations change depending, and I think you mentioned a little
Mhm.
bit about that. What does that tell us about communication and sex ed?
Yeah, I mean, I think you bring up a good point, not only about the education for ourselves, but also what is our partner learning,
Yes.
right? So if we
Yeah.
only learn about our own sex, then how will we have be able to understand the other? And so I love that you brought that up. That if you grow up in the same culture, you have the same background, or if you have the same sex education, you're gonna have those same issues. And how could we expect things to be different? But honestly, I would tell women, like, you're worth it and your orgasm is worth it. I hear a lot of people say it takes too long, so I just kind of forget about it. But would a man say that? Like, it takes so long to forget about it?
Right?
Like, no, that's what the entire sexual experience is about. And so really you should both be able to experience it.
Yeah, absolutely. So, how do you distinguish between, a woman who simply orgasms differently versus someone who has like female orgasmic disorder?
That's a great point. So I would say disorder in sexual medicine is almost always when it's associated with distress. So when it bothers you, right? So I have a lot of patients who are like, this is a very small orgasm, or I don't orgasm as reliably since starting this medication, but it doesn't really bother me. And that's the key. So if it really bothers the person, then it's considered a dysfunction or a disorder. And I would say it would probably bother them if they're getting sick or ill, right? So we see there's post-orgasmic illness syndrome. So that is something that's been documented where people actually become physically ill after an orgasm. We also see associated persistent general arousal disorder. So people are feeling constantly aroused when they're not wanting that. It's not always orgasmic, but sometimes it can be. And so those things are all areas where it's causing distress in a very obvious way. But for a woman who, for example, has gone through menopause and now can't orgasm, and her whole life she had really satisfying orgasms, and it was part of a satisfying part of her life, satisfying part of her relationship, and that's bothering her, then that's also considered a disorder or a dysfunction.
Yeah, definitely. So, some women have never experienced an orgasm. I'm sure you've seen that in your own practice. How
Yeah.
common is lifelong anorgasmia?
Yeah, so about 10% of women will have lifelong anorgasmia, never experienced it before.
Mm.
And sometimes when I talk to my patients, they really tell me, I'm not sure.
Yeah,
And I think where that comes from is because what else can they compare it to? Even if they talk to friends about it, which a lot of women don't do, in fact, it can be really hard to compare experiences. And what they see in movies is not what they're experiencing. So they're not sure if they've experienced the orgasm. A study I would love to do, Sadaf, is like interview or survey thousands of women around the world and ask them what an orgasm feels like for you, right?
Mm.
Because so many women will describe it as a release or riding a wave or this immense pleasurable experience that they can't really otherwise describe, or they feel like they're out of their head, right? And some women say, I feel it down to my toes or to my feet. And some women say they experience with orgasm where they feel it in their cervix and their uterus, which I have not had a patient tell me that, but other people have described it. And so it's like, I'm not going to refute that. Right. And so I think it'd be fascinating to know how everybody experiences it. But that's also what makes it difficult for women to know if they haven't, if it's been mild or if it hasn't knocked them off their feet, or if they haven't experienced it like that. They're like, well, maybe I never have. But truly, about 10% of women will fall into that category where they say, nope, I'm pretty sure I've never had an orgasm.
That's such a good point, and I think that would be such a fascinating survey, right? To do, just to ask women how they experience an orgasm, or what they think, an orgasm feels like for them, and
Yeah.
really compare it, because I wonder, that would be really fascinating, I think.
Wouldn't it? Yeah.
Yeah, yeah, 100%. I think that, and some people will feel it as like a general release, right? Like, I think
Mhm.
I remember a colleague, like one of my med school friends. I remember when we were talking in med school once, and she said, "Yeah, orgasm. It feels like when you are about to sneeze, and then you sneeze, and you
Yeah.
feel this, big release." And that's funny because that always stuck with me. And then I remember when I was talking to Dr. Barry Commiserak, and he said something very similar. He said it's like this full body tension, and then all of
Hmm.
a sudden you have this release,
Release.
you know?
Exactly.
So
Exactly.
it's so interesting. So that's kind of
Yeah.
what I tell my patients when they tell me that, they're not sure if they ever experienced it,
Yeah.
or they don't think they have, or what does it even feel like? That's kind of the
Mhm.
explanation I give them.
Yeah. I love that.
So what do you think clinicians are missing during the pelvic exam that contributes
Mhm.
to orgasmic difficulties?
So I think people need to be paying attention to the clitoris during the exam. I feel like even as a gynecologist, yeah, we were taught about the clitoris, but I also was taught try not to touch it, try not to bump it because that could be really uncomfortable for your patient. That could make her feel awkward or it could hurt her, right?
Yeah.
And so we do know that there's sensitive parts of the body that we try not to bother when we're examining people. And I kind of feel like the clitoris, and then hence the orgasm, has fallen into that category. But actually, clitoral phimosis, where the hood of the clitoris becomes fused to the glands of the clitoris, is as common as up to 20% of women. And that essentially creates a layer that is covering the access to those nerve endings. And so, whenever I see clitoral phimosis, even if the woman has not brought it up to me, I do ask her, are you experiencing satisfying orgasms or has anything changed? We see phimosis in lichen sclerosis commonly, lichen planus, other dermatological conditions of the vulva, but we also see it sometimes with genitourinary syndrome of menopause. So this is a great time to ask someone if they haven't brought it up themselves. And I have to tell you, sometimes my patients are like, nope, it's all been fine. I don't notice anything different. And maybe for her, her orgasm has always been like that. Maybe it's not a problem at all. Maybe that she doesn't need that part of the clitoris to be stimulated or to get that nerve ending stimulation to orgasm. Or, sometimes they say, yeah, actually there has been a change and it's been gradual and I don't know what happened. And so I think it's a great opportunity to notice. It's not just that covering, but you actually have to retract the hood or try to pull back to see, is it fused or stuck to the glands underneath. And I had a team of colleagues, friends of both, of ours, that we published a paper on clitoral phimosis and evaluating the clitoris for adhesions and phimosis that I can send for anybody who's interested in more of that topic.
Yeah, no, like you said, it's so important to evaluate the clitoris. And I know that, when I went through residency, we definitely did not focus on the clitoris.
Mhm.
We did a
Mhm.
vaginal
Yeah.
exam. We were just, kind of looking at the labias, and then,
Mhm.
we would find the vagina, do the speculum exam, get a pap
Yeah.
smear, and you were in and out. You did a pelvic exam, you were done. right? And
Yeah.
that was it. And it
You know,
was
I have a theory about that. Like the cervix is very hard to find. I feel like it took me quite a while to really reliably find someone's cervix because everyone's anatomy is different and we have to have a good view of the cervix to do a complete path. And so I think like that's where the focus is, trying
yes,
to find the cervix because it's so freaking hard.
yeah.
But the clitoris is not hard to find at all.
No, it's not. And it's just
And it
not.
won't take that much
Yeah.
longer to teach a medical student, to teach a gynecology OBGYN resident, to teach any resident how to look and evaluate at the clitoris.
Yeah, I agree. And, it's so, I mean, that was something that I was never taught. And honestly, I mean, I didn't even learn how to do a proper exam until I became a part of Ishwish. I mean, it just wasn't
Yeah,
like if you don't know, you don't know. Right. And so
exactly.
once you know,
Exactly.
though, then you'll never go back to doing it.
Yeah.
It's not
You can't
really
unsee.
incorrect.
You
Yeah.
can't see a
Right.
clitoris gets by most.
Yeah, no, you're absolutely right. And, lichen sclerosis, I just had a patient that had lichen sclerosis and she has
Yeah.
like almost complete clitoral phimosis. And nobody ever told her that. Nobody even told her she had lichen sclerosis. And I was like,
Yeah.
no, you have lichen sclerosis. So, anyways, but
Yeah.
yeah, sometimes I think as gynecologists, we try to rush through things, because we have so many patients waiting that,
Absolutely.
we uh, we can only do
Yeah.
our best. So
Yeah.
I loved your discussion about interoceptive awareness
Mhm.
about the
Yeah.
mind body connection. So can you explain a little bit what that
Yeah.
means when we're speaking about orgasm?
Sure. So Dr. Lori Brotto has
Love
talked about
Lori.
mindfulness and orgasm for many years, right? She's
Yes.
incredible. Her book, Better Sex Through Mindfulness, is also incredible. And so she's published on this for a long time. But this and interoceptive study I found was new when doing the research for this paper. And basically, what they said was that women who had higher scores of interoception, so that's having this mind body connection, tuning into how your body is feeling and being aware of that, had more reliable and higher frequency of orgasms. And so, although on one hand, we don't want to be too much in our head that we can't relax and enjoy an orgasm, we also can actually benefit from being mindfully connected to our body and sensing the pleasurable sensations in order to get to an orgasm. And so, I think that's a really interesting concept. And it's also something that's helpful, perhaps in our clinic, that if we have a patient who's had lifelong anorgasmia and she wants to do something about it, that might be an easier place to start, is to really tune in on this mindfulness and this mind body connection and sensation and being aware of sensation. And I think our colleagues in sex therapy have been doing this in lots of different ways for a long time. But just having that term around it, interoception, was really helpful to me.
Yeah, I think that, so I've had Lori Brotto on twice on this
Oh, nice.
podcast. Yeah, she's so amazing. I love her book. I actually we do a midlife women's retreat, and so I focus a lot on her book
Oh,
and for
cool.
better sex or mindfulness. And then,
Yeah.
also having Linda Weiner's book, right, on sensate focus, which originally came about by Masters and Johnson, and then she modified it a little bit. But I think that sensate focus and the mindfulness, all of that really helps. And you're right, not to be
Exactly.
too much into your head, but I think it's perhaps for me, what it seems like is just being fully aware of the sensations, right? Like
Yes.
how does the touch feel? How does the pressure? How does the taste? How does the smell, right?
Mhm.
Like just being really
Mhm.
aware of the senses so
Yeah,
that you can really enjoy what's happening at that time, right? For you.
exactly.
Yeah.
Exactly.
I've talked a little bit about spectating before, but can you explain this phenomena and why it interferes with pleasure?
Yeah, so it's actually the idea that you are conscientious of how things are looking as if you are outside your own body looking in. And again, it probably comes from us watching other people, from us watching TV, watching movies, and being aware of how things look, and then actually judging ourselves on how things look and how things are appearing, and really can just be so harmful for us from experiencing pleasure, because again, it's one of those things that when we're at that point of climax and we need to not care about anything else, and maybe this has evolutionary traces as well, like if you're in a situation where you're not going to care, you're in a safe setting, no other animal is going to come for you, you're not in danger, right? Like you're able to just totally relax. If you are spectating and thinking about all these other things, what does he or she think about me? How do I look? Do I look fat? Do I look old? Do I look all these things, right? Then you're not going to be able to enjoy that moment and climax.
100%. I think of when I explain to patients, I say like, spectating to me seems like kind of like an out of body experience, right? Like you're like up, like floating up and looking down at your own body and just kind of watching and it just really criticizing and evaluate. And you're so not in the moment that you just criticize and, are just unhappy with what you're seeing that you are definitely not going to orgasm
I've
because
exactly. I've never heard of spectating like in a positive way. It's never like you're like checking things out and you're like, yeah, you're doing great.
exactly.
It's always like negative.
Yeah.
So
Yeah.
yeah.
Yeah. So SSRIs are one of the biggest causes of orgasmic dysfunction. How should physicians counsel patients before prescribing them?
Oh, that is a tough one because mental health is also linked to sexual health. And we know that if people are depressed or anxious, it's going to affect their sexual health as well. And so we want you to have healthy mentality. We want you to be well mentally as well. But there are a lot of medications that their main or one of their main or most common side effects is going to be decreased orgasm or no orgasm or decreased arousal or decreased drive. And so I think it's important for us to warn people of that about that and also know that there are antidepressants and anxiolytics that don't cause those side effects. And maybe it'd be worth trying those first, especially if someone's already struggling. Now, not everybody experiences those side effects when they're on those medications. And so that's also important to share with our patients. But I just think with any side effect, if we're going to truly give people information, we need to mention the sexual side effects too.
100%. I just had a patient actually this morning in my office, and she's 17. And she
Oh,
was telling me that she was having some issues with her neck split on. But, anyways, so she was explaining to me that she has a lot of anxiety. So she was on some
yeah.
SSRI. And I said, did you experience problems with orgasm? She said, oh, 100%. She said, when I was on those medications, she said it was like I was a zombie. She's like, I couldn't feel
Well,
anything. She said, I felt
that's
nothing.
awful.
And,
Yeah.
she said that it definitely got better once she came off of it, but, while she was on it, it was really difficult. So I was explaining to her that, we do have medications that do not have sexual side effects that are used for anxiety and depression and stuff, but she said she had tried them, it didn't work, so, she may have to go back. But yeah, she's 100% aware and really upset of what it did to her sexual function.
Yeah, yeah.
Um,
That's really too bad. And sometimes it's a dose. And if you can find the dose that is benefiting your mental health but not causing the side effects, then you're golden,
yeah.
right?
Yeah, absolutely. So what exactly is post-SSRI sexual dysfunction, and why is it receiving so much attention now?
Oh, so unfortunately, some people will still experience the same sexual issues that they experienced while they were on that medication, even after they come off of it.
Oh,
And that's been documented to be able to last for years. I do find that a lot of my patients are able to get back to where they were before or find, relief. And we've got great medications now that will help people, whether it's libido, or drive, hypoactive sexual desire disorder. And I will say, I use those medications off label for orgasm, flibanserin and bremelanotide. If we know that drive and desire is going to lead towards orgasm, and that might be one of the issues, I do recommend trying those medications to help with orgasm. And there's some research behind that too. Similarly, testosterone, I feel like is an unsung hero, really to help with orgasm, although we might be prescribing it for hypoactive sexual desire disorder. So if you've been on an SSRI or an SNRI and you're worried that things are not going to get better, just take hope that we actually have great treatments that may actually be able to help you. But it's important to be aware that that might be why this came about.
yeah, amazing. So we talked a little bit about this, and so how can partners become part of the solution rather than another source of pressure?
So I think, really caring about your partner's orgasm, just the same that you would care about your own orgasm, is probably the first place to start. And that means if you don't know the anatomy or understand the anatomy, figure it out. Don't look to pornography to tell you what's normal. That's not a science. That's not science backed. Just in case you weren't sure, right?
Yeah.
Look for the science. I know you and I both have resources. I have information on my website, ourwomanity.com, that gives really basic information about anatomy. And that's where I would start if that's where you need to start. And don't be ashamed about that. The next thing is trying to understand with your partner what feels good to him or her, right? So whoever you are in your relationship or whatever is happening, just that open communication and bringing it up because your partner might not bring it up, I think shows that you are a safe space to talk about it.
Yeah, I love it. I love creating those safe spaces because you really, sex is a very vulnerable act. So you really need to have that safety and that consent when you are, engaging in sex. And so it's really important that you're able to have these type of conversations with the person that, you're going to become intimate with.
Yeah, totally. And unfortunately, I see women every day, and you probably do too, who've experienced trauma,
Yeah.
and that stays with them lifelong. And so we it's so important to have that safety in these relationships and consent.
Yeah. So what advice would you give to women who grew up believing that pleasure was shameful?
Hmm. I would say, you know what? Are there other areas of your life where you are finding joy or pleasure, and like remove sex from it? And how would you feel if you were no longer able to access that? So, if there's something that you feel like is valuable and giving you pleasure, then I feel like it's worth exploring. And if we think about orgasm from a scientific lens, then that removes the cultural lens from it and the shame and the stigma that's been around it forever, and allows you to just explore yourself based on facts. And if you can get pleasure from it, that's amazing.
Yeah. So what are some communication tips for couples when orgasm isn't happening?
That is that's a really tough one. That might be the hardest question because everybody is so different. And, I think being comfortable with one another can look a lot of different ways. And I think if you're struggling with it, then I would encourage you to talk to a sex therapist or a psychologist who has expertise in sexual medicine, because that is where you really need somebody objective to be able to assist you if you're not able to have an open communication between yourselves. I feel like so many other things are biological and physical, but this one really is interpersonal and psychological. And I guess I'd love to make that point, if you don't mind, that for so many years, I think people in the medical community thought women's pleasure was just psychological and sort of in women's heads, right? But there is biology, there's more besides the psychology. There's the neuroendocrine system, there's the nervous system, there's the pelvic floor, there's all these other aspects that are important for orgasm for women. But this one, when it comes to communication, is really a psychological intervention I think could help.
100%. I was reading, so I took this course through the University of Michigan on sexual counseling and education. It's like that
Yeah,
year-long program. And
yeah,
so one of the papers that I read for that course, a few years ago, and it talked about the number one factor for female was it to increase female sexual satisfaction was communication. So
interesting.
yeah,
That's
so it's
fascinating.
really, really important for
Yeah.
us to be able to have these open conversations with our partners. And I know that for a lot of people, that seems really difficult. And sometimes, partners may think that, that they're not really being scolded, but they're being like, oh, you're not good enough, or you're not good at this, or you're not good at that. And it's really not about that. It's just about learning each other and
Yeah,
learning and understanding what, causes pleasure for the other person, and really trying to hone in on that if you really care about the other person, is to,
exactly.
make sure that both people are, enjoying the experience, and it's not
Yeah.
just one person.
I would give your listeners this tip. You know, use this podcast as your example to normalize it. And
Yeah.
when you normalize something, then that takes away that personalization or blaming of the person for the issue. So you could say, hey, I was listening to this awesome podcast, the Muslim Sex Podcast, and I heard that 10% of women never experience orgasm. Can we talk about that?
Yeah.
How are your orgasms? Are they satisfying for you? Is there something else that I could do to help you? Let's just have that conversation, right? You normalize it so it takes away that blame or pointing a finger.
I love it. I love it. Yeah. And actually, I think they say that when you name something, you take away the shame from it, right? So
Yes.
So
Yes.
when you are talking about something, you actually put a name to it, like, oh, I'm not experiencing orgasm with you, or maybe, I'm not experiencing as much pleasure as I'd like. And,
Yeah.
can we do something about, can we both maybe learn the anatomy? I'm not saying it that you don't know, but, maybe I don't know my own anatomy. And so maybe, you and I can learn it together, something like that, right?
I
Where it
love that.
kind of
Yes.
opens up that conversation piece. So it's not
Exactly.
right. It's not a blaming game. It's just, let's learn together. So I
Exactly.
think that's more, collaborative, and I think that's helpful.
Yeah.
Just some rapid fire questions for you.
Sure.
So, true or false? So, myth or fact? Most women orgasm from penetration alone.
Myth.
The myth, that's right. Every orgasm looks and feels the same.
Myth.
If a woman can't orgasm, it's all in her head.
Myth.
Menopause means the end of satisfying orgasms.
Myth. Big myth.
I know. I think we'd all be in trouble for those of us going through perimenopause or menopause. So, vibrators make women unable to orgasm without them.
Myth. Vibrators are awesome.
Yeah, they sure are. Pelvic floor therapy can improve orgasm.
True.
Yes. Anxiety is one of the biggest barriers to orgasm.
Ooh, can be. It can be.
Yeah. Communication is as important as anatomy.
True.
That's right.
True.
So, what's one thing every woman should know about her own body that she probably wasn't taught?
Hmm. I think you should know, like every woman should know that you have a pleasure center, this organ that is really just for making you feel good. And you should learn how to
It's
benefit from
built
it.
in, right?
It's
Like,
built in.
right,
Yes,
it's just there. So,
exactly.
yeah, to make use of it 100%.
Yeah.
And what's one thing every partner should understand about female pleasure?
It changes. It may change if they are pregnant, if they're on medications. It might change through perimenopause and menopause. It might change how the woman gets there. It might change how she feels, but it's still worth pursuing.
Yeah. And what gives you hope about the future of women's sexual health?
Hey, you know what? Having this paper published in the Green Journal gives me hope about
Amazing,
real
right?
sexual medicine, right? Because
Kudos to you.
if
Yeah,
you didn't
absolutely.
learn that much about orgasm in your residency, and I didn't learn that much about
Yeah,
orgasm in my residency, then think of the thousands of OBGYNs who didn't learn that much about
I
orgasm.
know. I know.
And so having a paper published in our highest impact
Yeah.
journal that outlines
Amazing.
orgasm as something worth reading about, something worth learning about, I think is huge. So I have a huge gratitude towards the Green Journal for taking the time and not just immediately rejecting it. You know, for the reviewers who went through and gave us great revisions, and for my co-authors who helped work on this with me, I just feel like that gives me hope that even if there's so much that we don't know about it, it's out there, and now we have to continue doing the work.
Yeah, what's great is that it being published in the Green Journal shows that it is a priority, right? That it is important. And the Green Journal is, kind of like I don't want to say it's like the Bible, but I mean, it's, it's ACOG's
Yeah.
journal and, highly respected. So for you to
Yeah.
get a paper out, and that's really phenomenal. So
Thank you. My
congratulations to
hope,
you.
every year we have to do our continuing education. We
Yeah.
have to read a bunch of articles. My hope, if anybody's listening out there who makes these decisions, I hope that it becomes one of the
Yes.
readings,
Required readings.
right?
That would be
Yeah.
amazing.
Yeah.
Amazing. And last thing, so if listeners remember only one message from this conversation, what would you want it to be?
Oh, only one. I think what I want them to remember is if you are struggling with it, with orgasm, that is, and it's worth it for you to get there or to spend time on it, there's treatment. And we actually have some information on how to make things better. So even if it's that you get my paper and you bring it to your physician or advanced practice provider, or you read it yourself, right? It's worth it to take the time because sexual health is your health. And if you are not well in that part of your health, then it's worth taking the time to figure it out.
Yeah. Yeah. I always say that.
Orgasms are healthy. Orgasms are good for
Oh,
us.
they're fantastic. And what I always say that like sexual health, I feel, or a person's sexual history is kind of like, well, really, I think maybe their sexual health is kind of a barometer of their relationship, right? So
Absolutely.
it really tells. I always say like whatever's going happening inside of the bedroom is also happening outside of the bedroom. So if you're not talking about things, if you're ignoring it, if you're, it's probably also happening outside of the bedroom where,
Mhm.
other things aren't as I would say sensitive, right? So
Yeah. And you know what? If that is the situation with you, or if you are single, you don't need a partner to have an orgasm.
yeah, yeah,
That's
yeah.
another thing that I would want your listeners to take away from this. Like, you don't need a partner to have an orgasm. You can have a really high quality experience of pleasure on your own.
Yes, 100%, 100%. So for all of those people that are listening, that are watching, that are like, wow, Dr. Rachel Pope is so amazing. How can I get in touch with her? How can I listen to more of what she has to say? How can they get in touch with you?
Thank you. I would say please follow me on Instagram. That's where I try to post everything and anything that's going on. So I'm at Dr. Rachel Pope. That's RachelPope. And, I have a podcast of my own also about women's sexual health. And so you can follow it there. But I post on my Instagram where you can get links to the podcast. I have a fellowship for people who want to train in female sexual medicine and reconstructive surgery. And if you're interested in that, go to my Instagram. Really, I try to put everything in one place there because otherwise we're all overloaded with information.
Awesome. Amazing. Well, thank you so much for coming on. And it's been real and really intimate. Remember, this is not meant to be any type of medical advice. If you have any questions about your sexual health, make sure you go see your healthcare provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.